Hi, my name is Sandy Tennis, and I'm going to be talking about leukemia in adults over the age of 65. So, a little overview of leukemia. It is a type of blood cancer that starts in the bone marrow. It is estimated that over 60,000 new cases will be diagnosed in 2016 alone. Leukemia is the 10th leading cause of cancer, and the median age of diagnosis is 66. In the picture on this slide, you can see the multiple systemic effects of leukemia, and we will be talking through those in this presentation. So there are four main types. The first one is acute lymphoblastic leukemia, or ALL. It is the most common type of leukemia in children, but it can also affect adults. It responds fairly well to therapy and carries a good prognosis. Acute myeloid leukemia, or AML, is the most common type of acute leukemia in adults. It also responds fairly well to therapy, but prognosis is a little worse than ALL. Chronic lymphoid leukemia, or CLL, affects primarily older adults and is much more slower growing than the acute forms. Many patients can live many years after diagnosis, and therefore watchful waiting may be the appropriate treatment. It does respond poorly when the patient does need therapy. Chronic myeloid leukemia, or CML, also affects primarily adults, and it responds poorly to therapy. Prognosis may be improved after a bone marrow transplant. So next we'll be talking about the hemopoietic changes, which is the primary pathology of leukemia. Genetic material of blood stem cells in the bone marrow is damaged. This forms leukemic lymphoblasts that proliferate abnormally and crowd out healthy blood cells like WBCs, RBCs, and platelets. This leads to neutropenia, which increases the risk for infection, anemia, which causes fatigue and shortness of breath, and thrombocytopenia, which increases the risk for bleeding. And in the elderly, they already have a decreased circulating blood cell as a result of aging, and therefore these effects can be even more noted. Cardiovascular changes are a pretty rare occurrence. You may see ischemia, cardiomyopathy, or valvular dysfunction, and this is usually related to the side effects of chemotherapy. Studies have shown cardiovascular improvements once the chemo is changed or discontinued. Other noted infiltration effects have been pericardial effusion, tumor thrombosis, and/or myocardial infiltration from leukemic cells. These are usually noted upon autopsy, and therefore the prognosis is poor. Respiratory changes of leukemia. You may see acute respiratory failure develop fairly quickly with leukemia due to opportunistic infections and non-infectious leukemic lung changes, such as pulmonary leukemic infiltration. This is infiltrations that occur in the interstitial and alveolar spaces in the absence of infection, and so it doesn't usually show up on chest x-ray. You may see a ground glass appearance if a high-resolution CT scan is done. Leukostasis occurs because the patient is typically in blast crisis and has a high peripheral blast count leading to endothelial injury, and blast aggregates or clumps clog up the vessel lumens. Acute lysis pneumopathy occurs immediately or shortly after chemotherapy induction and is response for diffuse alveolar damage. These changes, coupled with the normal aging process of the lungs, predisposes patients over 65 to increased shortness of breath and pneumonia, and can lead to extensive hospitalizations and may require ventilatory support in the intensive care unit. Urinary changes. These tend to be fairly rare with leukemia. If we do see them, they're usually related to leukemic infiltrations or after chemotherapy. Patients present with acute renal failure and/or enlarged kidneys, which is also known as nephromegaly. Acute renal failure is usually associated with tumor lysis syndrome within the first few days after chemotherapy. And so you see the typical lab values of increased uric acid, potassium, BU, and creat, etc. that you see with acute renal failure. These patients may require hemodialysis or chemotherapy or a combination of both, and can actually recover from the kidney involvement. Gastrointestinal manifestations of leukemia occur in up to 25% of patients generally during relapse, and is found on autopsy. Its presence varies with the type of leukemia and has been decreasing over time due to the improved chemotherapy being used. Gross leukemic lesions are most common in the stomach, ileum, and proximal colon. Infiltration of the lymphovreticular organs, mainly the spleen, liver, and lymph nodes, is prominent in the chronic versions of leukemia versus the acute versions. Therefore, these patients come in with hepatomegaly, splenomegaly, and lymphadenopathy, and is quite common in leukemic patients. Musculoskeletal complaints will be of muscle, joint, and soft tissue tenderness and pain, and these are common with leukemia and frequently can be the presenting complaint before the patient is actually diagnosed with leukemia. They may also present as an effect of chemotherapy and are referred to as post-chemotherapy rheumatism or arthropathy. Neural and sensory changes, these are also rare involvements for leukemia. Complications can result from leukemic infiltrations, infections, thrombocytopenia-related bleeding, or be related to the effects of chemotherapy. Symptoms may mimic normal age-associated changes like mental status changes, weakness or balance problems, but they may also include headaches, neuropathy, and intracranial hemorrhage resulting from the decreased platelet count. Next, we're going to talk about leukemia risk factors. There is no clear cause for any type of leukemia, but there are certain risk factors that are associated with the disease. So with the modifiable risk factors, obesity is one of them, and this is in response to endogenous metabolic hormone alterations that increases the potential for leukemia, and therefore recommendations would be along dietary modifications to reduce weight and reduce obesity. Cigarette smoking and exposure to benzene increases the risk of leukemia. Therefore, smoking cessation programs would be recommended. And certain medications and radiation exposure also increase the risk. Medications we don't typically see a whole lot anymore, like chloramphenicol, phenylbutazone, chloroquine, and methylsporin have triggered leukemia. One that kind of caught my attention was acetaminophen also has an increased risk with leukemia. Therefore, recommendations would be to avoid these medications that pose an increased risk and also to avoid radiation exposure. Under non-modifiable risk factors, age is one of them. Leukemia is often diagnosed between the ages of 65 to 74. With gender, males associated with higher incidence, no matter what the ethnicity is across the nation and across other countries. And in a literature review, there was no clear indications in any literature that were studied. Race and ethnicity found Caucasian prevalence over African American, Hispanic, or Asian Pacific Islander. So recommendations would be to provide closer screening and observation in primary care provider offices for CBC results and patient symptom complaints, especially in the above risk population. So goals of treatment. The goal of treatment is to destroy leukemic cells and allow normal cells to form in the bone marrow. Treatment is based on the type of leukemia and its stage, along with the patient's general health. Common chemotherapy treatment for acute leukemias like AML and ALL begins with induction chemotherapy followed by consolidation chemotherapy. So I'm going to describe those a little bit. Induction therapy kills leukemia cells in the blood and bone marrow to induce remission. Treatment includes chemotherapy and corticosteroids. This usually lasts for 4 weeks, and the patient is typically in the hospital for these full 4 weeks. Consolidation therapy is also known as intensification therapy. This is used to destroy any remaining leukemia cells that cannot be seen in the blood or bone marrow, because if they're allowed to regrow, they will cause relapse. So treatment includes more chemotherapy and possible stem cell transplantation, and this can last over several months. Maintenance therapy is used to reduce the risk of the disease reoccurring after the treatment is finished. Treatment involves lower dose oral chemotherapy or once a month IV therapy and can be continued up to 3 years. Oral chemotherapy is commonly used for the chronic leukemias like CML or CLL. So now we'll talk about the nursing care interventions. And the primary interventions tend to deal with prevention and close assessment. And so, again, talking about dietary considerations to lose weight and avoid obesity, avoiding smoking and exposure to benzene, looking into smoking cessation programs, avoiding high risk medications and exposure to radiation, and being alert to complaints of weakness, fatigue, frequent infections, and weight loss, especially in the elderly, and looking at those CBCs for neutropenia, anemia, and thrombocytopenia. Secondary interventions, when this patient is actually diagnosed with leukemia, there's a lot of education that needs to happen. And so we need to educate the patients and their families about leukemia, what that diagnosis means, about chemotherapy, the side effects of both the disease and the medications. Infection prevention is very important, and also what a neutropenic diet would be. So neutropenic diet consists of avoiding uncooked vegetables and most fruits, avoiding raw or rare meat and fish, and avoiding undercooked or uncooked eggs. Also, it's recommended that patients consume only pasteurized milk, yogurt, cheese, and other dairy products. Also, an interprofessional approach to care is needed, especially while the patient is in the hospital. So not only will they have their oncologist and their primary physician, there'll be an oncology nurse, social service will be involved, case managers, chaplains, dietitians, and a lot of programs also have patient navigator that helps assist the patient and the family through the process. Blood transfusions, because we talked about how their blood counts are low, so frequently they will need transfusions. And the induction chemotherapy, again, they'll have up to 4 weeks of that in the hospital. Pain and symptom relief is very important in this phase because there's a lot of symptoms and issues that go along not only with the disease but also with the chemotherapy and other medications. And then typically also while they're in the hospital, they'll be provided referral to the American Cancer Society so that they can always get ongoing assistance, education, and support. Tertiary management is kind of the management of the disease. So again, infection prevention is very key for these patients. This is where then they'll move into the chemotherapy consolidation and maintenance aspects of chemotherapy. They'll also need to be provided other information on the available therapies that may also go along with their treatments. So radiation, biologic therapies, bone marrow transplantation. Clinical trials will be explained to them. So there are trials available for every type of leukemia and at every stage of treatment, as well as those in remission. And then leukemia support groups also will be very important for these patients. Technology-based care. There's a lot of technology that's involved in the care of the chemotherapy patient just right off the bat. So these patients, once they've noted on the blood smear that there are leukemic cells present, they will do a bone marrow biopsy where they'll get a sample of the bone marrow and use it to determine the type of leukemia. A PET scan or a CAT scan will provide information about the extent of leukemia. Flow cytometry can provide valuable insight into whether the tumor cells contain normal or abnormal amounts of DNA and the relative rate at which the tumor is growing. Chemotherapy usually consists of giving several drugs together in a set regimen because combination may make the cells more vulnerable to treatment. Targeted therapy. So unlike the chemo that affects all the cells in the body, targeted therapy directly seeks out leukemic cells, helping to reduce the damage to the healthy cells and minimize side effects. Frequently, these are used in combination with chemotherapy. Radiation therapy may be used to destroy leukemia cells or palliatively to relieve pain or discomfort. It may also be given in low doses prior to bone marrow or stem cell transplant. Bone marrow transplantation or stem cell transplant may be used to restore healthy bone marrow in patients with leukemia. It stimulates new bone marrow growth and restores the immune system, which is one of our goals of therapy. and then information on internet sites. So there's all kinds of sites like the Leukemia and Lymphoma Society, American Cancer Society, National Cancer Institute, many that patients can go to and their families can go to for more information and support. This is my concept map, and it basically goes through the things that I've talked through. So the pathophysiology of the abnormal growth of blood stem cells forming leukemic lymphoblasts, crowding out the normal cells, leading to neutropenia, anemia, and thrombocytopenia. Next over are the modifiable risk factors of obesity, medications, and smoking or radiation exposure, and we spoke about interventions for those. And then farther to the right is the non-modifiable factors of the age over 65, males, and the Caucasian race. So in conclusion, leukemia, again, it's a blood cancer that begins in the bone marrow. There is a higher incidence in ages 65 and older. It has no known cause, but the primary symptoms are related to neutropenia, anemia, and thrombocytopenia. Systemic effects are noted from the disease process and treatments, and usually requires a multimodal approach to therapy. Thank you. I hope you enjoyed my presentation.